Very good evening and a warm welcome to all the respected participants. My name is Ashish Tukkal. I am representing GE Healthcare Cardiovascular Ultrasound segment. Today, we are going to conduct an exclusive clinical lecture on strain echocardiography on our XP Connect webinar education series, powered by Vivid Cardiovascular Ultrasound Technology from GE Healthcare in association with CSI Ranchi. Patients today increasingly have a combination of disease, which may need a paradigm shift for conclusive diagnosis. This requires a more comprehensive view of the cardiac patient, and question arises is EF enough or strain should be used in clinical practice. For the same today, we have with us renowned names in the field of cardiology. Dr. Satish Kumar, President of Cardiological Society of India, Jharkhand chapter. Dr. Arun Kumar sir from Ranchi. Dr. Dipak Gupta, Director of Cardiovascular Sciences, Pulse Hospital, Ranchi. I welcome you all, sir. Now I would like to call upon Dr. Satish Kumar, sir. Sir is a well-known name in the cardiology community and has been contributing immensely, be it educational initiatives, research paper, training, relentlessly to name few areas. Before we get started, due to huge traffic load on internet services, if you experience temporary interruption in the transmission, kindly bear with us. We will sort it out immediately and resume. I now welcome the esteemed faculty, Dr. Satish Kumar sir, to address our viewers. Over to you, sir.
Hello, and a very warm good evening to all of our delegates and colleagues from Jharkhand and from the whole of India. And few of them, I believe, have also joined from as international listeners or learners of the arts and science of echocardiography. So, good evening to you all. Friends, we have today a very learned and accomplished echocardiographer and I would say a learner, even at this age of the arts and science of echocardiography, Dr. Arun Sarkar with us. And as we all know that the topic selected for today's discussion is strain echocardiography, and we know that during the whole process of evolution of echocardiography, this is the latest thing that has come into the foray, and the evolution is related to the science of computational power of different computers that has been embedded in our systems, machines, and as we know that earlier, traditionally we have been estimating the left ventricular function and other things through either M mode or Doppler echocardiography. But as our computational power became faster and faster, we were able to do more. Not only we could estimate the velocity of the blood that is circulating in the heart and different vessels, but also we could assess the movement of the tissue, and thereby later on tissue Doppler imaging came with harmonics imaging and all. So these were developments. But later on, after certain scientists recognized, particularly Torrent, Guas, and Streeter, that our heart muscles are not merely some, muscles made of flesh or cavities. They are in fact arranged in certain fashion, which is very important for their function. And they are in fact like the towel wrapped around and making a cavity, and their movement is very much, predictable. And it is important. I'm sure Dr. Sarkar will be elaborating much on that, and with a very vivid and educative kind of videos that he has prepared with the help of his son, I believe, and we'll be learning a lot. So once we knew that these muscles are in a particular fashion, we were able to pick their movements, their what we call speckles. So we could pick the and that was very good information. Once you compile them, with the faster computational power, you are able to give a lot more information to a clinician, not only as a left ventricular ejection fraction, but in other fashion, as he'll be telling us. What is called strain and strain rate. That is the topic of today. So with that, Dr. Sarkar will be taking over. He's the son of the soil from Jharkhand itself. After doing his post-graduation from RIMS, he has been very active in echocardiography. And I would say that very few people are at this age are as inquisitive for this science of echocardiography than he is. We have to learn a lot from him. So without much break again, I would invite Dr. Sarkar sir to come and start his deliberations. Dr. Sarkar sir. You, yeah. You're mute.
So just one thing, yeah.
Hello, I am audible?
Yes,
sir, very much.
You can go ahead. So just single click on your PPT once, then it will change. Okay.
So today's topic is the advance in echocardiography. Strain echocardiography is a new advancement in the field of echocardiography. It's also called the spectral tracking. The robust workshop and the informations are going throughout the world. Every moment there is addition of the new ones. Of course, there is a standardization and the validation which are accepted by the American College of Cardiology and the European Cardiological Society. We're simply astonished to see what the echo machine can do. In today's workshop, we'll discuss and understand the basics related to the subject and spend some time on the pattern recognition. Before starting the strain echocardiography, please look at this video. Here the Arjun is concentrating on the target that is a bird's eye. This is a bird's eye. After failed attempts by the so many Kaurav and the Pandavas Rajkumars one by one, the Guru Dronacharya asked Arjun, what do you visualize? The large tree, its branches, the moving leaves, or the sitting bird? And by the way, what is the color of the bird really? The Arjun replies, he can't see anything except the bird's eye and nothing else. So he is unable to answer the color of the tree. The Guru encouraged and said, oh, you release the arrow, Shabas, and he have hit the bird's eye. This is the power of concentration. But if you see inside, you can see the reflection of the Arjuna. And more concentrately, there is something. So today's the discussion, not the bird's eye, but the bull's eye. Today's target is the bull's eye. This is the bull's eye. What at a glance we can have so many informations. How we analyze this bull's eye? the left ventricular peak systolic ejection at a glance. Here you see the 17 segments of the left ventricle and a crescentic right ventricle in the bullseye format. Some numbers are also there in each segment, but everything appears hazy here. It will tell so many untold stories, and we will gradually unfold it today and discuss in detail. We started our echo journey by understanding the 2D echo. This is the Plaque's view, and this is the M mode. You see the excursion. It is a still picture, but with the M mode we can see the movement pattern. You can have some idea of the left ventricular ejection fraction here, and this is the anterior mitral leaflet and the posterior mitral leaflet in the different phases of the cardiac cycle. And this is the color Doppler. Inside the cavity, you see the flow of the colors, and it is towards the flow. The red means it shows the direction. So there is a mitral flow, but if it is a monocolor flow, but if there is a mosaic, there must be some disturbance, some turbulence is there. So it is a apical view. There appears to be a defect in ASD. Once you put the color, you can see the flow from the left atrium to the right atrium, the flow moves. So it's really a reliable one. And till now, we are only seeing the blood flow. This is in the frequency, and this is the amplitude. So high frequency, low amplitudes are the cavity. Within the cavity, the flow we can see. The hemodynamic assessment we can do. But these tall waves, the high amplitude, but the low frequency, these are this myocardial pictures. So this is the wall filter. So if you put the wall filter, we can visualize the ventricular details, and that is our aim, because this can give indirect the hemodynamic changes, but once we have to finally evaluate the ventricle. And you see here there is nothing seen in the cavity, but the left ventricle shows this color. So different phases of this cardiac cycle. This is in systole, the S waves, and this is in the diastole, the E prime and S prime. So you have to understand this cardiac cycle. So in the motion you can see how it looks. So this is the systole and it is the diastole, but in between it's not moving. Probably this is the in the isometric relaxation phase. So we have to know something, the basics about the cardiac cycle, which unless you appreciate those things. Heart beats 72 times a minute. So one cardiac cycle is less than a second. Actually, it is a 0.8 second, and that's why these are the two concentric cycles, and I have made the inner cycle as a atria and the outer cycle as a ventricle. So, and one segment is the 0.1 second. So this is the atrial systole, 0.1 second, and then this is this ventricular systole, 0.3 second. So this is the first heart sound, lub, and this is the dub, the second heart sound, once the systole is complete. And the semilunar valves open here, and this is the ejection phase, the maximum ejection and the reduced ejection phase. The AV valve open, then the filling phase starts, the first rapid filling phase, and the last rapid filling phase which coincides with the atrial kick, and this is the diastasis. So this is the isometric relaxation phase, and this is the isometric contraction phase. So these are the cyclic events that goes on in the lively every time. But in real sense, we have to simplify it in the linear fashion. In every textbook, the cardiac cycle is explained in this linear fashion. So I have cut this cycle and it's straightened just like a ribbon. You see, this is the atrial phase and this is the ventricle phase. This is the first heart sound. This is the second heart sound. This is the 0.3 second and 0.5 second. This cardiac cadence goes like this way, lub, dub, lub, dub. And And next, just you see the how I build this the ventricular pulse pressure. This is the atrial, slightly high, and this is the aortic pressure. So this is the pressure changes. This is the scale of the pressure. So really in the cardiac cycle, there are 4 cyclical events we record. This is the pressure, this is the volume, this is the electrical activity, and this is the sound. The first heart sound, the second heart sound, and this goes on. And you see this. Then we ask, why are we discussing this much? To analyze the strain curve. What the strain curve is there? So strain is actually the change in the fiber length. So this somehow matches with this one, the volume curve. But what we will analyze gradually. Actually, this green is the second from the bottom one. This is the electrical activity. This is the axial potential of the this atrial waves. The electrical things initiates the mechanical change. You see, after this, the atrial activity starts, atrial kicking. And atrial pressure is slightly more than the ventricle, that's why the flow is there. And once the ventricle overshoots its, this is the mitral valve closure, the first heart sound. And then this is the isometric contraction phase, and this is aortic pressure. It is near about the 80 here, you see. And once ventricle pressure goes more, then it opening of the aortic valve is there, and this is the ejection phase. And when the ventricle pressure falls, then there is a closure of this. So this is considered closure of the aortic valve. This is important of the closure of this aortic valve makes the completion of this systole. This is very important. This line is just just remember this line in doing the echocardiography. Importance of this line is there. So about the strain imaging, today's topic. So what is strain? Its meaning, the definition, and how we measure it. Strain means the deformation. In simple sense, the strain is the change in the shape. This is the simplest definition. Due to an external stress. You see how this shape changes of the mouth and the eyes due to the external stress. Just see how simple. This is a cartoon, but the strain is the measurement of the deformation. But the question is how we should measure that. How we measure that. You see, these are the two pictures. The movement is there in both of the pictures, but there is no change in the shape. But here it is just doubling. So change is the magnitude or deformation is equal to the change in the dimension from the deformed object is from the original dimension. So how we measure that? The strain is this change in the length, the L minus L0 by the original length. So this way we can have the magnitude of the strain. These two pictures, you see, it has also some changes. This is also changes, but these moves rapidly. This is slowly. So to understand the strain rate, we have to go to these two cricketers. This is the Gale and this is the Dravid. Both makes the 50 runs each. But the ball faced by the Gale is the 20 balls only, and Dravid does it after batting of 110 balls. So the run per ball is the 2.5, and here the less than half. So that is called the strike rate. Similarly, this is the strain and this is the strain rate. Both may have the same changes, but how fast it's moving, that also matters. That is called the strain rate. These are two types of the myocardial strain we do. One is the tissue Doppler and the speckling. There's a slight difference in that. At the beginning, the strain was derived from the left-sided picture. This is called the Doppler imaging. But it is the angle dependent. But the speckle, you have to see the small myocardial speckles are there. Computer recognizes the speckle pattern. How it does that? Say, here the speckles are there. There are definite speckle patterns are there. So frame by frame, they pick up the change and then they recognize its movement and the fiber length also. Similarly, you see the changes are there. So how this was this guy which is moving from the back bench to the coming from the front. See how the software recognizes the facial pattern of the person and its pixel details frame by frame and tracks the, even there is so many noise of the moving papers. This face recognition, the speckled pixels is a game changer advancement in the science. You see, the China and South Korea has proved this face recognition technology and controlling the corona epidemic and controlling their countries so fast. There, every movement is recorded in the face recognition and conveyed by the WeChat. You cannot hide the travel history there. But here in India, the Telecom Regulatory Authority has not allowed it because it interferes the privacy of the individual. That is a different story altogether. We should not deviate from the subject today. Anyhow, here we see how we use this speckle pattern in two places. In those two places, if that is recorded by the computer, then we can have some fiber length, and then how it moves. So let's see here. This is the original fiber length. There's definitely a speckle pattern, and same speckle pattern has moved in the systole when it is contracted. So this is the L0 and the L final length, and frame by frame that is recorded. So let's example. This is the initial length, 10 millimeter, and the final length is 8 millimeter. And the strain is the change in the length by the original length. That means it is 8 minus 10 by 10 into 100. So 8 minus 10 is the minus 2 by 10 by into 100 is the minus 20. How this minus come? Because the final length is shorter. That's why it comes to minus 2. So this is minus 20 here. How simple is the equation? And this normal left ventricular systolic strain ranges from minus 16 to minus 22. This is one of the important take-home message. Please remember, the minus means it is a contracting. Minus means it is a contracting. So minus 16 to minus 22 is the normal LV the systolic strain. Frame by frame, we have to record the whole thing. Now watch this hummingbird. Normally you cannot see the wings of the hummingbird because it's moving so rapidly. For that you have to select the high resolution fast speed camera with high frame rates such that it captures all the details. See how here it is done. All the pixels are captured and displayed, speckles tracked and shown in the video clipping. But one thing is that things must be not out of the focus from this camera lens. Okay, so technically you have to select a machine that is capable of capturing the high frame rate pictures so that can show the movement details clearly, frame by frame in the graph. So there is 3 types of direction of the strain, how this pixel moves. It may move in the longitudinal things, it may move radially, or it may move circumferentially. So this longitudinal strain is the negative strain, but the circumferential strain is the shortening. Practically, we are only measuring the longitudinal strain. So if you ask anyone to squeeze the water from the wet cloth, invariably they perform the unique and the same action of twisting of the hands in opposite direction throughout the world. This clockwise and anti-clockwise motions of the hand needs no special instruction or training because it is quite natural and spontaneous, and this is the only one and the best way of squeezing the water. In this way, heart has also the spiral fibers. That's why in 3D stain picture shows that the outer fiber of the myocardium and the inner fiber are moving in the opposite direction, and ergonomically spending only 12 to 13% of the energy and having the 60% of the ejection fraction. So how ergonomically yielding, just you can imagine, it is only because it has spiral fibers. But in the 2D strain, you cannot pick this fiber moving. It needs a 3D strain because it is not moving in this one direction, one plane. So this is another things, spiral fibers, and the real how it moves. See the natural motion of the helical or the spiral fibers of the heart moves clockwise at the base and anti-clockwise in the short axis. It is very clear. Oh, really, it is amazing to watch. So conceptually, there are three types of strain I have already described: the radial strain, the circumferential strain, and the longitudinal strain. Jointly squeezes and push the blood, thus the normal ejection fraction is there. Among which, if you see, the longitudinal strain is the maximum. It is clear by the size of this sphere. So these are the two comparative things to understand why it's necessary. It is a case of the preserved ejection fraction with a decreased GLS. In both the cases, you see the ejection fraction is the same. See in these two examples, one is normal and another is the preserved ejection fraction with the decreased GLS. This one. It is important to notice that the longitudinal strain which first affected and but it is compensated by the increased size of the radial and the circumferential strain. The first changes seen is the reduction of the global longitudinal strain, and this is very early in the process of the disease. This is called the subclinical myocardial dysfunction, and this happens in so many common conditions such as the diabetes, hypertension, obesity, metabolic diseases, and thyroid dysfunctions. The incidence is increasing day by day. We are facing these problems every day in our clinic, so we have to catch them early and act accordingly. So, if the EF is considered, till the EF is considered to be the gold standard parameter to evaluate the myocardial function, but it has some limitations. There are the intra and the inter-observer variability. EF is a good predictor in the late phase of the disease, but not in the early preclinical phase, especially in the HFpEF or the EF correlates well when it falls below 35%, but not before that. There is a shift of the paradigm. Now the GLS, means the global longitudinal strain, is an established parameter and early indicator which works as an index of the myocardial quantification more objectively. Thus, the serial GLS values can guide in future outcome and the management. So the consensus, what we do is not only the ejection fraction, but there is with the addition of the fine touch, there is a GLS. So what is GLS? The GLS means the global longitudinal strain. It is actually addition of the all things in a straight line. But if you consider, it is not actually, it is in one plane, it's in a line which is parallel to the endomyocardium, but it appears as a sheet when you consider all the planes. That is the normal, it is near the -20. So how we do it? From the apex we take this apical long axis, apical 4-chambered, apical 2-chambered views as shown in this picture, and in the different levels. And this bull's eye shows this is the inner circle is the apical part, the mid one is the mid-zonal, and the outer circle is the base, and this one is the this crescentic one is the right ventricle. Here is a patient of a with the cancer chemotherapy. You can gradually see all the deterioration. Here is -20, then -17, then -16.1. So you can understand its deterioration here. These are the normal 3 apical planes. So how we do it, the methodology, by a demonstration, just you see. This is my clinic, I'm explaining it.
How we do it? At first, to set the Ecg electrodes, because here Ecg is a measuring tape as well as timer of the show. We acquired the video clippings in the standard 3 apical views, first in the apical long axis and then 4-chambered, and last in the apical 2-chambered. It is better to dialogue with the machine to mark the mechanical systole in the memory print of the Ecg panel. Here you see the aortic valve opening and closing line, and which is a marker of the systole, the duration. Now every patient is a corona suspect, so we have to protect ourselves fully from bottom to top. We don't know if we get victory or not, and we have to prepare for our patients and for the equipments, the probe, everything. See, the blue color is the aortic flow. We are recording the aortic flow velocity in the apical 4-chambered, 2-chambered, as well as the apical long axis view. These are the video clips explored, and we can get all these important recordings in this clip. And you can get the colored M mode and the graph. So, all views of the different cardiac cycle, but rightly compared, keeping the proper timings and the event recordings. This is AFI. Doesn't mean the artificial intelligence, but it is automated functional imaging. You have to keep your own intelligence with you and quite conversant with the machine. The machine will pick up the spectral patterns of the contractile myocardium as shown in the picture, and you can adjust the exact location of the endocardial linings. See, here we are doing in this anterosceptal wall, and different colors are there for each individual segments, and this is the once this is complete, in the lower panel you can see everything, the boxes are the green with a tick mark. Here it is important to test the machine. The vendors can fool you. So to test this sensitive machine that is really pick up the contractile myocardium or not. Now I'm shifting these dots outside of the contractile tissue and see what happens exactly. In the anterosceptal wall, I became the red. Now I'm again shifting these dots to the original position and again see, it became the green. So really this machine is the sensitive to the contractile myocardium. This brings confidence to the machine as well as your performance. So all the three views are captured sequentially. It covers the 360 degree of the myocardium. See in the last apical two chamber views, the views are covering the last 60 degree gap. So there is a gap of 60 degrees. Now all of things are become green, then fully captured the 360 degree. Finally, you get this bullseye. We can see all the 17 myocardial segments at a glance. So central is the apex, and then the peripheral region is the basal segments. Anterior eccentric shape, so it is the right ventricle. Strain values with the matching color shades, and on the segments itself. The comparative graph we can analyze, and we can get the post-systolic shortening in the according to the with the addition of the single click.
This is how we perform. Let's see what the World Authority says. He is a professor, Dr. Thomas Binder, director of the Echocardiography Laboratory at the Medical University of Vienna. He conducted more than 100 international echocardiography courses, and he's a tutor for the Austrian American foundations. Listen what he says.
Especially if you're using the so-called automated functional imaging program, which is built into the machine. I would recommend that you start with a pulsed wave Doppler, because here you can actually define when aortic valve opening and aortic valve closure is. Let's take a look at this tracing that we acquired here. Now, this would be aortic valve opening, and this very sharp echo at the end is the aortic valve closure. All we now need to do is go into the measurement program and tell the system that this is actually aortic valve closure. So we'll go here, enter this point, and now the system knows that 364 milliseconds after the QRS complex, this is the time point when aortic valve closure actually occurred. Next, we'll just retrieve the studies of the patient that we acquired earlier, starting with the apical long axis view. It's important to start with the apical long axis view because this is actually what the system will prompt you. We will now open again the automatic functional imaging program and tell the system this is the apical long axis view. Next, we will try to find the region where we need to place the 3 points, namely the basal posterior, the basal anterior septum, and the apex. Note that the image is moving back and forth a little bit. This is very important because this allows you to see the endocardial contour much better, because our eye is actually used to analyzing moving images and not stills. So here you can nicely now define the 3 points. We'll place them right in the middle of the myocardium, right here. Here is the basal anterior septum, and this is the apex. So you see, the contour was found quite nicely. If you're not happy, you can reanalyze it. I might want to change the settings a little bit, so I'll just recalculate it and maybe move the basal segment a little bit up here because I don't want to be too far in the mitral valve. So let's say I'm happy, and I will now press process, and the system will now automatically find the contours. I mentioned previously that we can define the aortic valve closure with help of the pulse wave Doppler. But it's not always necessary to use this measurement because frequently the system will be very, very exact in defining the moment of aortic valve closure based on the curves, based on the information that is retrieving from the speckle tracking image. So this is now the analysis that we're getting. And since we're happy with it, we will simply approve it and then tell the system whether or not we want to use the measurement of the aortic valve closure that we chose or leave it to the system. If you move the cursor a little bit away from the bright green line right here and then press enter, it will ask you, do you want to use the automatic or the event timing? Or do you want to even define it manually? So in this case, I think we'll probably take the event timing because we were quite sure that this was really the best moment when aortic valve closure occurred. Now we have the completed analysis. What we get an overlay where the different colors tell you how good contraction and relaxation is. Contraction defined as a negative strain, very red would denote a normal strain, while blue would denote relaxation. If you look at the image during systole, it's all red, which already tells you that this patient has a completely normal strain. In the bottom left, you will see a number, -20. This is the global longitudinal strain in this individual view. If we want to look at all the other views, of course, we will need to also analyze the 4 and the 2-chamber view. And that's exactly what I'll do right now. I'll move to the 4-chamber view, choose the view which it is, which is the 4-chamber view, enter 3 individual points, tell the system, yes, I'm happy with it, go on with process. The system will now find the contours. I'm happy with it. I'll approve it. And here again, we have the speckle tracking analysis. And finally, we'll go to the 2-chamber view. This is a 2-chamber view. I'll tell him this is the 2-chamber view. I will again add the points, 1, 2, and 3. Now, one other thing you can do, if I'm not happy with the region of interest that was found, I can also change the width. I can do this by turning the knob that you see right here, and all of a sudden, I'll be focusing on a different part of the myocardium, in this case, more on the endocardial part. So let's process this and see what we get. Again, it detected all the individual segments. I approve, and here we go. Here is the final analysis. We have all the 3 apical views that we were using. We've got the bullseye display. Take a look at the global longitudinal strain. You can do that by going into the bullseye display only. We have -20.4, which denotes a completely normal longitudinal strain. Our patient was a young individual. We see the regional longitudinal strain, -24 here, for example, -17. Now there is a slight reduction in strain here in the basal parts of the myocardium, which should not worry you. Very frequently we have this region as the region where we have the least strain. Importantly, there's always some degree of difference between the apical segments and the basal segments, with the apical segments being higher. So this concludes the analysis of the bullseye display and also shows you how simple it actually is. I find it quite important to also look at the curves because they do give you additional information. What we see here is we see the different views, the 4-chamber view, the 2-chamber view, and the apical long axis view. Each of these curves corresponds with an individual segment. You can actually look at that segment. For example, if I go into this bullseye display, you will see which segment is meant. In this case, the apical anterior segment, the mid-anterior segment, and the basal anterior segment. We have the ECG down here, so this is the time axis. We have the degree of contraction or strain here in this axis with a baseline which denotes 0. So everything that is below the curve is negative strain, which means contraction. Also note that we have a time point, which we defined previously, which is aortic valve closure. Each of these curves shows a little square. This is where the value for the peak systolic strain of this individual segment was measured. It has to be before aortic valve closure. So you see it's usually the maximal peak before aortic valve closure. You can adjust that. If you're not happy with it, you can actually enter and move this back and forth a little bit, and you will see that actually the value in the bullseye display will also change. In most situations, it's not necessary to really change this. What you can also see is you see that in all of the segments, contraction occurs pretty much at the same time point, which is very important because this means that contraction is more or less synchronous. Now, you can have different curves, for example, in bundle branch block or in other situations where there's an abnormal pattern of contraction. But it's important to know this. So in summary, as you can see, if you combine the information, the bullseye display, with the curves, you can get a lot of information which will be very valuable in specific clinical situations, as you will see in later chapters.
So we'll learn more to discussing these cases. These are the selected cases taken from Dr. Thomas Binder's case files. Already proved diagnosis and well discussed throughout the World Forum. All these cases give some take-home message. So let's start. First, we'll deal with the normal LV function or not, then the hypertrophy, then cardiomyopathies, then chemotherapy, then dyssynchrony, and coronary artery disease. And if you'll get time, then we can deal with the ALA strain assessment. Now, this is the first case. Just every case you just see the pattern recognition is the most important things you have to see. So this is a young woman coming from a bar and fainted. You see, she is fainted here. And she was brought to the emergency room and echocardiography was performed. And see the echo. Close look of the four-chambered apical views on the long axis. So the good global function. Is this a normal echocardiogram? EF appears definitely normal. What does the strain values tell us? Let's see. We'll see that the bull's eye display, the beauty of getting this picture, everything is at a glance. It's completely red. So it tells that it is normal. The longitudinal contractile systolic function, the blue color represents the states shows the dilatation or lengthening. So if you see these values and the GLS is minus 25.2, it appears slightly more than the normal or the normal range. But the young lady might have had the high normal values, and the patient might have the hyperdynamic and maybe nervous, could have a high catecholamine surge at the time. What exactly happened at that time, we cannot know exactly. There is no past history. This is a single and the first incidence reported. So no event recorder or the Holter monitor was applied. We have not expected also. Analyzing the bull's eye further, I will see that, notice that the regional disturbance of the strain pattern shows the normal. This normal gradient is important. You see, this is minus 23 and this is minus 27. So gradually, it is more in the apical part. So this is final impression is that it is a normal cardiac function. Next case. An elderly patient, the history of the arrhythmias, the family history of cardiomyopathy. The father and mother both has a DCM. Mostly sedentary. He was not exercising very much. So we do not know if there is any dyspnea or not. He went to a doctor for echocardiogram, and this is the echocardiogram. Now the big question is this a normal ventricle or not? What is the ejection fraction? Look at the short axis view. See the systolic thickening, which tells you about this radial function. No wall motion abnormality is there. The patient is sick. The patient is sick or have any deterioration of the function due to the development of the dilated cardiomyopathy? We have no clear-cut answer for these signs. Okay, let's see. After the first sight, you will see that it appears red. But if you look in detail, it is lower than the slightly normal. It is only in the lower range. And there is a difference in the shade. So these are the slightly lighter than the central. So this is a subclinical form of the DCM. Next question, should we start the treatment? We took the final opinion of the experts in this case. They say that they agree in the one point that GL strain is very good at this time, but it's deteriorating in the basal things, and diagnosis of the subclinical myocardial dysfunction. They further guided we should repeat in regular interval to compare the objective values of the strain to assess the progressiveness of the disease. We can initiate the beta blocker and the ACE inhibitors therapy at this stage. These are the very benign drugs and may be helpful in the slowing the disease in the phenotypic expression. So you have already similarly experienced using these drugs in the cardio-oncology segment. So case 3, a 45 years old ex-bodybuilder who was planned for a shoulder surgery. An echocardiography was performed as a clearance of the pre-operative protocols. He has already on the steroid for last 25 years. See the heart. There's definitely the left ventricular hypertrophy is there, and even the global longitudinal function. And note there is a spontaneous echo contrast is there. Even the global longitudinal function, it is minus 14.2, so it is less. This patient was already have a subclinical left ventricular dysfunction. Probably it is related to the long period of the steroid abuse. We can definitely differentiate from the athlete's heart because he is a bodybuilder, and there are some differences with the left ventricular hypertrophy because we have to treat this athlete heart either there is LVH or not. In the next slide you will see these are the basal strains, apical to basal gradient, and the global strain. This is the athlete without LVH and athlete with LVH. Here the basal strain in the normal athletes is mildly reduced. You will see from the normal population it is reduced, but once they are in the exercise, they bounce back. It's more than the normal. But normally they have a very silent heart and the heart rate is low. So basal strain is reduced at that time. It is not abnormality. But in athlete with the LVH, it is moderately reduced. The apical to basal gradient is high here, but it's lower. The global strain is normal, but borderline or mildly reduced here. By these two things, by seeing the strain pattern, you can easily detect this athlete's heart with LVH or without LVH. So we have deal with the normal LV function. The next is the hypertrophy. This is the second topic, and it's the enlargement of any organ, is the organomegaly. In case of the heart, it's called the cardiomegaly. There may be the hypertrophy, there is pseudo-hypertrophy, when there is an increased deposition of the cellular matrix and or the metabolic things in the amyloidosis or the storage diseases. There may be the hyperplasia, metaplasia, or neoplasia. In all these cases, the hypertrophy might be there. So please see these two calf muscles here. One is hypertrophy and another is a pseudo-hypertrophy. Here both the volume is increased. So this is a weightlifter and this patient of a Duchenne muscular dystrophy. So even then there is a increased this volume of the muscle, they may be weak. See, this is a Goa rising up test. This boy climbs with himself. This is the Goa rising. The neurologists rely more on this test because this gives an idea of a muscular dysfunction the power, and that's why we are doing actually myocardial functioning test. This strain echocardiography, the speckle tracking, actually we are testing the myocardial performance. But in another different case, we just watch, we'll see, because of a hypertensive heart disease, there is a marked LVH. The radial strain is increased. It is compensated because it is remodeling. At different level you see there is a very increase. So here you see the ejection fraction is compensated. So here ejection fraction is 53%. But if you see the strain, there is a marked reduction in the basal and mid segments. So what about the strain? It's quite good evidence of the LV dysfunction. See the different reduction in the strain, especially in the basal segments. The GLS reduced to 13.4% only. This is the typical finding what we get day to day in our clinical practice. Longitudinal strain reduces first in the early phase of the disease. The hyperdynamic radial strain, better seen in the short axis view, compensates and drop in the longitudinal strain at this time shows the normal EF. It gives a false impression of the normal LV function. Usually treatment is delayed, as in this case happened. So this is the pathophysiology of this hypertension. You see all the 4 stages. If you consider only EF, in the stage 1, stage 2, stage 3, they are all normal. And it starts reducing only in the stage 4. And you see the LV size is normal, but here it is small because of the improved radial strain. But if you consider this longitudinal strain, it starts deteriorating early from the stage 2. So if you see this progression, stage 1 to stage 4, and strain pattern from -23, -19.2, -16, -14, and -12.1. And you see just the involvement of the segments, the basal and mid segments, and last one only sparing of the apical segments. This is the end stage condition of so many diseases, and this is called the cherry red on appearance over the cake. We have put the cherry. This is very classical in the amyloidosis, but may be seen in so many end stage diseases, because at last the radial strain though increases, but the longitudinal strain is spared at the apical region. So before that, in the diastole, before doing the strain, we have to do the E by E prime, because we have seen the LA pressure is increased or not. If the E by E prime ratio is below 8, the LA pressure is normal. But if it goes more than the 15, there is increase. But within the 8 to 15, from 9 to 14, the other things has to see. There is another case, the 74 years old male with a proven amyloid heart disease. What I am telling about the amyloid disease, just watch. There is a ground glass appearance, a storage of the things, and there is a myocardial fiber disarray here. So, and this pattern, only the apical longitudinal part is only retained. So this is the classical, the amyloid heart disease, but this is not the pathognomonic of the amyloid, but it is seen mostly in these cases. So hypertrophy you have done, then we will go to the cardiomyopathies. Cardiomyopathies may be the apical cardiomyopathy, the hypertrophic obstructive cardiomyopathy, or it may be the non-obstructive cardiomyopathy, and the DCM, the dilated cardiomyopathy. Strain is the focally reduced in those segments here, but in the DCM it is the diffusely things. And if you see the different patterns here, not a good echo, the quality of echogenicity is not very good, but you see the 2D pictures in the motion, apical 4C, 2C, and there is a apical thickening. Apical thickening is very clear here, and you see just opposite of the amyloid and end stage disease have seen. So this part is deteriorated. That means the apical myopathy, apical longitudinal fibers are gone. There may be the increase in the radial contraction in those things. You see the radial contraction is increased. That gives a false impression. But here the longitudinal strain is decreased. So this is the apical cardiomyopathy. And this is the septal hypertrophy. Just you see there is a increase speckling in the septal region, and you see the on the septum how it is only focal area is involved. The septum also the lateral wall, and MRI has differentiated that. MRI also shows these differences, and gadolinium MRI shows there is a gadolinium MRI, which clearly this picture is inserted because comparing with the MRI, you see what information we are getting here, the same information we are getting the MRI and also in the strain imaging. So this checkup gives a much more confidence to the very cheap things and the bedside things you can do and get the equal informations. All these cases, as you've seen in the gradual progression, there is a gradual deterioration of the longitudinal strain. Not only that, there is also increase in the fibrosis, and there is a high chances of the arrhythmias and applying the AICD. So this is the cutoff value that 12 point, the cardiac event-free rates, and this is the once you follow these cases, once it falls below the 12.9, so the literature shows the lower the strain values, poorer the prognosis, and the cutoff value is 12.9 here. So you can make this is a decision-making thing. You see, this is a hypertrophic obstructive cardiomyopathy, basal segment. This is the basal segment. So here it's not involved the other segments also, only the basal septum and basal apical wall, and that is causing the dynamic obstruction here. So this also matches with this pattern. So this pattern recognition is also important here. And watch this case is a DCM case, and eccentric enlargement of the ventricle with some non-compaction part is there. The LV, LVs, RV is the only non-compacted part, or the straviculations are there, but in LV it is very clear here. And this part, the green, blue segments, what you visualize here, it shows it's part of this also dyskinetic. But everything is that it is not a specific pattern, it is diffusely involved. So this is a case of a DCM. So as this disease deteriorates, you see the strain values reduces from 17.5 to the 7.3, and last the end stage disease, only the apical segments are spared. Sometimes there is a confusion that DCM with the ischemic heart disease. So this is a diffuse involvement, and here you see this is a DCM, but here you see This is the position of the left anterior descending lag, and this is one segment, the LAD distribution, and it is also part is also dyskinetic. So we have go to the next thing, chemotherapy. It is also called the cardio-oncology. Chemotherapy, this comes under the cardio-oncology, is a vast chapter, but today we'll concentrate only on how to evaluate the cardiotoxicity due to these chemotherapeutic agents. Before starting the topic, please look at the video clippings of this case. 14 years old girl with a leukemia who received chemotherapy and the bone marrow transplantation. 8 years later, this echocardium, this is 8 years later, the poor LV function, reduced global, the longitudinal strain, the LA, LV are markedly enlarged, and you see due to the annular dilatation there is a marked MR also. There is also the pulmonary hypertension, and there is a pericardial effusion as well. The strain patterns shows the severe reduction in the GLS, and he has a severe heart failure, and the sad story is that this patient died, the tragic end. Some question popped up in my mind. This patient was not died due to the leukemia itself, but due to the chemotherapy related heart failure. Next important question is that, can you be able to save this patient? If seen earlier, these are the list of the cardiotoxic medicines. When a patient does not tolerate any drug, or there is a drug reaction, in general, we immediately stop that drug and rescue protocols to save the organ and the life of the patient. But that is not true in case of the chemotherapy. These agents are usually act slowly on the targeted tissue and takes over the years to precipitate, as seen in this previous case. You cannot stop the chemotherapy then and there, because all these chemotherapy agents are the life-saving steps for the patient for that time. Nowadays, non-specific and severely toxic drugs are usually not in use. The oncologists also follow the scientific guidelines and the protocols. They utilize the pulse therapy, the tissue-specific, the targeting agents, the shield the vital organs, and keep the vigilant eyes on the side effect of the patient of these drugs. The anthracyclines are the notorious. The doxorubicin, non-rubicin comes under this, and then the taxanes. The docetaxel is the important group, and then the monoclonal antibody. The MAB ends with the MAB, the taxuzumab, and the other things. So what is the rule? You have to early detect. How we know that there is the cardiotoxicity? This slide guides us in this way. It is established that the strain is a sensitive and early indicator of the deterioration of the myocardial function. There is a gradual reduction in the strain values progressively, seen in this patient who is taking the chemotherapy. We have to do the regular strain analysis and comparing the baseline strain values with each value. If there is a less than the 8%, if there is a 8% reduction, there is no chemotherapeutic induced LV dysfunction. If it is below 8, so you have to compare every time. But if it is more than the 15% cutoff value, of which we should be cautious and initiate the treatment protocols. Between 8 and 15 is the ambiguous state. So, if we only consider the ejection fraction, if it is below 53%, and there is the cancer-related chemotherapy is there, but that comes very, very late. The ejection fraction is more than the 53%, so there is a relative drop in the GLS we have to compare to the baseline. If it is less than 80%, that is okay. There is no evidence of the cardiac dysfunction subclinical, but if there is more than 15%, then there is a subclinical dysfunction. We'll see the next cases. You see here the baseline case. Baseline echocardiography is done, and a 59 years old man with AML started chemotherapy, but he has also the hypertension, and echo done at the 4th day with a 58% increase in the radial strain. So what is the, considering ejection fraction, the 66 minus 58 this comes to the by 66 is the 12% decrease. So it is below 15%. But if you consider the GLS, then 17 and 14, and in both the cases you see the troponin level is high. The change in the strain is the 17 minus 14 is the 17%. So this comes under 15%. So here you see that within 2 months, if you just evaluate the longitudinal strain values, it indicates that a cardiotoxicity has started. Because this is a definite evidence that what you need more here to see the shredded basal septum, and the cardiotoxic drugs affects this inner part of the endocardium, but the concentration of the longitudinal fibers are more. And this is a direct evidence. What evidence you need more? So here is the protocol. Just you see the baseline evaluation of the patient. The three things we see: the ejection fraction, GLS, and the troponin. So if the ejection fraction is less than 53% and GLS is less than 18% and troponin is plus, the cardiology consultation is done. But if the EF is more than 58% and the GLS is more than the 18%, then the troponin level is not increasing, the serial troponin levels, then there is no evidence here. But you have to evaluate in every 3 to 6 months. But if in the evaluation this LVEF drops more than the 10%, 10 points, or this is the EF below 53%, then this is the CT diminished, chemotherapy related cardiac dysfunction. And relative, but it comes later. But if the relative drop in the GLS as compared to the baseline, if it is less than the 8%, there is no evidence of the subclinical dysfunction. But if it is more than 15%, so this is the things what we have discussed earlier. But it is a nicely things it is shown here. So these are the subclinical changes and is overt heart failure from symptomatic LV dysfunction, how it moves towards the this biomarker elevated troponin levels from asymptomatic reduced LV function to asymptomatic subclinical. So our aim is to put this patient from the overt heart failure towards the subclinical changes, push this patient towards this direction. Here you see the angiotensin converting enzymes and beta blockers. We use it very commonly, and this is the responders. So from 1 to 2 months, 2 to 4 months, and within 6 months, if you used earlier, if you use it within the 2 months, the 64% is responding things are there. So you need this GLS evaluation, how it is important, it shows here. I'm showing the case, the 64-year-old woman had a HERS positive. HERS is a protein called the human epidermal growth factor receptor 2, with the infiltrating lobular carcinoma of the right breast, and with the positive ductal carcinoma in situ, the left breast, and this preoperative chemotherapy, the paclitaxel and the taximab. The paclitaxel was discontinued after 8 fusions due to the toxicity and the neuropathy. Then preoperatively started the doxorubicin and cyclophosphamide, and see the echo. Ejection fraction was 65%, the pre-treatment, and this is the staining image. Shows the after this 3 months there is a on the 59%, from 65 to 59%. There is a relative reduction is 29%. So there was 17%. If you consider this GLS, 29%. So it is indicated the GLS is more than 18% from the baseline. It appears if it is more than 15%, so 29% more than 15%, of course. Then so this patient from 65 to 59% relative risk ratio, and GLS turned to minus 17%, the 29% risk. So started with the Corec. Corec is the beta blocker and NRAPIL. Initiated adjuvant trastuzumab was continued. Even see, this is the mild cardiotoxic, and the other drugs also. Serial echocardiography every 2-3 months was done, and from 59%, the GLS was minus 17%. That is improved after 1 year. So this is the evidence. We have started this beta blocker and things, and there is evidence. So this builds up the confidence how you shield and protect the heart, and early detection is necessary. So these are the persistent troponin levels. So without the drug, but here you are seeing the AS inhibitors, and from 43% the difference is just reduced to the 0. So this is the definite evidence of cardioprotector drugs. This is a very clear-cut evidence that how this chemotherapy, we are already using the conventional age-old medicines in so many clinical conditions for the years together. Actually, we have to rethink over this matter, and can be hypothesized that could be a unified universal theory that environmental toxins, pollutants, and also the damages of the heart in the similar, it affects the heart also in similar way, that could in the maybe more slowly. It may take the 15 to 20 years. So using these medicines we are also using. So this is in short about the chemotherapy. Then we'll come to the desynchrony. This is the SA node, and this is the AV node, and this is the bundle of His and the bundle of branches, the Purkinje fibers, and you see the thick myocardium, but atria is a thin myocardium. The population of the myocardial cells are more in the ventricle. That's why they put the larger amplitude waves here, but the P wave smaller, because the population does not create so much of chorus which reflected in the surface ECG. This is a large chorus of the ventricular muscles. And not only that, TARF and the narrow ventricular complex, it shows the synchrony. It's all the muscles are synchronous and contracting at each time, just like this picture. The beauty of synchronicity. You see how the synchronicity. Historically, echocardiography was a routine procedures. This is a non-compaction. 62 years old lady with a RV apical pacing. Now presented with the decompensated heart and the pleural effusion and the cardiac, the large desynchronous part is there with the conduction abnormality. Remember this strain. Okay, let me come to the strain values. So you see here, all the fibers are, this is called the dispersion. No fiber has in the same peak. So they are conducting in the different time. So results after the CRT, a biventricular pacing and correction was done in the same patient. The LV function much more improved. You see, there is some improvement over there, indicating this delayed contraction part is not there, and here is also only this part is still and the non-compaction part is there, but there is an improvement and improvement in the ejection fraction as well. So role of specular tract imaging in the CRT. We have known that is to read the strain curve in the dispersion pattern and selecting the patient of atypical versus typical LBB and selecting the patient for a scar or a desynchrony and effect on the CRT and the lead placement and optimization. Till now, only clinical and the ECG, if it is the QRS duration is more than the 150 millisecond and the ejection fraction is below 35%, then it is considered, but the strain echo may play a helpful role in this. I think so. Desynchronous part is we have now this coronary artery disease. Everything in the world is the spherical, but heart is heart-shaped. You see, the lower part of the heart is the ventricle. So there is a ventricular cavity and left ventricular cavity, and this is the crescentic right ventricular cavity. This is the interventricular septum. We are drawing this the grooves. The atrioventricular groove. This is the interventricular groove, and all the three main coronary arteries: the right coronary artery, the LAD, and the circumference follows and runs in these grooves. And all the intervention is also done in this apical this coronary arteries. So more we can see here. This is the RCA. It is a complex. It moves with the atrioventricular groove. These are the right ventricular branches, the branch to the SA node, and these are the ventricular branches. And a long branch is there, the acute marginal artery, and it moves in the crux. There is a PDA, and it may go to the supply if it is dominant in the posterior basal segments, and there are the ventricular branches, and 1/3 posterior 1/3 is supplied by the septum, is the PDA. This is the circumflex, this is the LAD, and these are the diagonal branches, and these are the long anterior 1/3. If you see in the short axis, this is the LAD. So this is the diagonal, and this is the anterior 2/3 is supplied by things. So this is the position of the AV node. These are obtuse branches are there. Position of the TX is here. So normally we do in all these planes all the regional this coronary arteries and regional wall motion. Just we analyze, watching mainly the endocardium. You see all the parts of the endocardium moving equally into systole. But if one part is lagging behind, slightly moves less, then it's called the hypokinesia. And if it's not moving at all, then it is the akinesia. And if it's moving in the systole in the opposite direction, this is the dyskinesia. But our main aim is to have the print on your brain, the how. At a glance, you can see in the bull's eye, you see the whole thing is red is the normokinesia, which is slightly different in the shade. Light red, it is the hypokinesia. More whiter is the akinesia. But if it is blue, that means it is not contracting, it is dilating. This is the dyskinesia. But this is the normal concept. You have to just see and make a memory print in your brain. This is very, very important thing. To analyze the graph, this is very, very important. An eye-opening experiment was performed. This patient was trained for the echo simultaneously during the stent implantation. The balloon catheter, this is the baseline, and as this balloon catheter was inflated, just you see, and I show you this is the systole, this is the aortic valve closing line. So this is the contraction of all the left ventricular musculature. So everything ceases here. Once it is contracting, the whole the function of the LV ceases here. So this is very, very important. But there is a post-systolic contraction. This is called PSS. After the stent implantation has been done, and see, it regains the functionality here. And this is also gone. So this is the recovery phase. But if it is there, if you recognize these post-systolic things, that means there is acute insult. With the, if there is a this changes in the systolic wave pattern. Here it is absent, but there may be the mild reduction. So this gives a eye-opener things, and how we analyze this thing in our clinical practice, just you see. The recommendation is that post-systolic shortening is abnormal. If the PSS means the post-systolic shortening is a transient one, there is a preceding systole is abnormal, that is clearly reduced or the bulging, and the PSS exceeds the 20% of the systolic deformation. This is an example. This is the post-systolic shortening is there, contraction is there, but it is less than 20%. But here there is abnormal reduction in the, you see, this shows the -20, means the GLS value. So the marked reduction in this GLS value here, and this is the more than 20% of the total GLS value. So this is indication of the pathology. Here you see, this is the kinetic, akinetic, this is the LAD, and here LAD also moves the posterior part because it is overlapping here, this part also. But you also watch that in the inferior wall there is also some abnormality. Small posterior infarct is also associated. So if you consider here, it is not seen, but is in posterior inferior myocardial infarction case. You see the inferior myocardial infarction. The inferior wall is here you show this small part is there. Here you see the inferior wall is moving. So strain values shows that. Not only that, this is a temporary or not. How can you understand? Because this is a different case. This is a case of a DCM with a smoker, very obese. The BMI is 40 and hypertension and diabetes. Watch this case and watch especially in this area. A slightly abnormality is moving. Some wall motion abnormality is there. Everyone must recognize this case. Here also, the lateral and the inferior wall, there is some abnormality. But when we analyze this curve, these 2 points that they compare, the normal values, they are contracting normally. There is no abnormality. And what is exactly it is? MRI has been done. You see, there is a increased number of this fat here. This is the fat. And during the contraction, this fat pushes every systole here. Can you watch this thing? If you compare with this one and our MRI with a echo, it appears the same. That means when you put this, if you rely on these graphs, if this extra cardiac tissue, which is not has no contractile power, it is not showing the speckle tracking as matching with the contractile myocardium. That means it is extra cardiac things. So this test must generate confidence over the machine and your performance, and relying on this graph patterns. So how important is to this training curriculum to understand this graph? That's why these examples are shown here. A case of acute MI, and see the akinetic, dyskinetic anteroseptal wall, and especially near the apex. The left-sided picture, after 6 days post PTCA. You see, this is the curved, anatomical curved things. So this part shows that there is a whole things in the systole, but this part is akinetic dyskinetic. Here it shows it is dyskinetic here. To analyze the graph, we have to see three things. The contractile force, that means here you see all the synchronous waves are there and their strain values in the scale. So a good contraction LV, and all the particles, all the things are contracting simultaneously and before the systole, the closing of the AV valve, and now there the relaxation and the lengthening part is there with the atrial kick. And but here it shows the hypokinesia. The total GLS is low and there is a reduction in the values. It is gradually, and or the akinesia or dyskinesia. So the timing of the activity is also necessary. And third one is this elastic properties. Even here there is a post-systolic shortening and there is lengthening, but you see from the baseline the curve is the fluctuant one. But if you see this purple line, this is almost flat. So this indicates the fibrosis. Nothing can be done here. If the viability, this shows the viability. So amplitude either in the this way or this way. So this shows that still the elastic property is maintained. And this is the post-systolic shortening. Then there was a very marked varied question. Why this? You have said the viable, but if it is contracting also, anything goes down, it is contracting. Here you have seen it is contracting. This is contracting. It is going down. Here is also contracting. So what is the problem here? But if you see, this is the active part in the with active myosin contraction, and this is the active contraction. But this is the passive contraction. This is not this is the recoil actually. I'll show you this thing. I have explained this thing. Watch.
Your question was how this dysfunctional myocardial segment, which is dyskinetic and bulging in the systole, is contracting here. This is the line of the contraction, because this is a passive contraction, not in the systole. That's why it is called the post-systolic contraction, which is pathognomonic of these fibers, which is this viable fibers. So it is acutely insulted fibers. Okay, this is the active contraction which happens in the systole. This red line, vertical line, which is this event recording has been done, which is the closing of the aortic valve. So this is the systole and this is the diastole. So you see how this normal fibers, which shows the good negative strain, and this is how good the strain values are there. These are the normal myocardial fibers, which is contracting here, and this is relaxing here, and this is the lengthening. So this is the lengthening and this is the contracting. So I'll explain it here. You see, this is the elastic band. Okay, so this is the elastic band, and these are the dots which will show the contraction. So this is the normal tissue, normal myocardial fiber, and this is the dysfunctional fiber which bulges out. Okay, so in the active systole, when there is an active myosin contraction here, when it contracts in the systole, so it contracts here, and you see the shortening, and you watch here, this fiber is lengthening. So when after the systole, just we release, and it is contracting. So this is the passive contraction. This is the pathognomonic of the viability of this elastic fiber. This is called the elastic property that we explained. The third point was the elastic property. In many cases, in the scar tissue, the whole thing is replaced by this fibrous tissue. So there is neither shortening, neither lengthening. So it doesn't show the active contraction here. So this is replaced by the fibrous tissue. So nothing can be done in this case. In the graph you see, this is the flat curve. So this is the pathognomony of
the fibrosis. So all these informations we can get very easily through this graph. Now coming to the same case. Now coming to the same case of the acute anterior anteroseptal MI, what I've seen before this video. See the 2D picture, the 2D picture, the stain dots here, and the red appears in the systolic contraction, which fails to contract in the systole. This is near the apex, this part. And the post-systolic shortening is there. So it is the hallmark of the acute insult. Was this purple line? This is the dyskinetic part, and you see how the dispersion is there. So this is a definite evidence of the acute insult, and more than 20% of the these values are there. Not only the dyskinetic part, but also in the different region. The blue color is also seen here. Okay, so we get this thing in the strain analysis here. All these segments we can separately see. The normal, the posterior segment, the posterior basal is this yellow, and gradually this is the things, and purple is here. So if you can match this color, one of them, and you can easily pick out which segment is exactly problem. Not only they have this view, but also the mathematical value of these things and their timing and everything. So PTCA must be indicated. This is definitely evidence. So next thing, after the 6 days of the intervention, just you see the changes in the graph. You see how synchronous, how nicely. This is called the functional. They have restored the functionality of the all myocardium, the timely intervention. So actually, the last this thing I was interesting, so that this is a thrilling experience. As the interventionist get the thrilled examples after seeing the TIMI3 flow again in this myocardial valve, that is immediately proved. But it is also not less gratifying to see the functional restoring of the myocardial, the salvage the myocardium. That's why I'm indicating. So I'll quickly go to the next this left atrial assessment in short views. You see the left atrium is a thin. It has 3 functions, mainly the reservoir functions, the conduit, and the LA, and the pump. So if you see the cardiac cycle, again, the point 1 is the atrial systole. The atrial cycle is something different, and atrial diastole is the 0.7 second. So in this 0.7 second, is mainly the reservoir and the conduit function. So, and it is only the pump function is the smaller one. So, if you see here, this is the left ventricle goes up, and the atria also. This is the same cardiac cycle, but after this opening of this AV valves, there is a suction is there, and the atria dilates here. So the reservoir function, conduit function, and this is the total reservoir function. You have seen the left ventricle left atrial strain, it moves upward because it dilates, and the LS strain means LV strain, it goes down because it's contracting. We are upward moving is we are seeing the accommodative value is elastic properties, and moving downwards is the contraction. So it's a positive strain of a plus 40, and you are measuring the accommodative power. But the left ventricle has a negative strain is of the minus 16 to minus 22 value. Measure the contractile power. Here you see, we have done this left atrial alignment in our clinic to see it's possible or not. Here is not the left ventricle, but left atria you are seeing. And everything here you see appears blue. We do normally the three conventional things. This is the apical long axis view, and you see it moves up. That means it's a dilating. And also in the apical 4-chambered view and apical 2-chambered view. So everything appears blue because it is dilating, not the red. And the red is very high. It is more than the 40, plus 40, not the minus.
When atria contracts, see how the ventricles dilate. With every atrial kick, the ventricle dilates. But when ventricle is in the phase of the contraction, the atrial dilatation is due to the venous filling, serves as a reservoir function. So you see, atria and ventricles are inversely related. Atria contracts, ventricle dilates, and just the opposite, when ventricle contracts, atrial dilatation is there. We measure this contracting process of the ventricle as a negative strain, that is minus 16 to minus 20, red in color in the bullseye. But atrial functions are measured how much dilated it dilates, its accommodative power, mentioned in the positive strain value, blue in color, and its normal is plus 40. Not only that, we also watch whether atria retains its elastic property or not. Its expansile stretching of the normal and the normal recoil, its nature in the graph and its pattern is important. A flat curve denotes the fibrosis, the consequences to the atrial fibrillation and the ultimate thromboembolic disaster.
You see, this is the course of the progression of the disease and LA suffers badly. we have to be vigilant about in every stage, right from the fibrosis, which is very early, then the inflammatory and the prothrombotic stage, and the LA dilatation here, and the stasis, the atrial fibrillation, and the thrombosis and the stroke. So normally we start the anticoagulation when you see the pulse or any clinical events of the syncope, or proving that in the ECG. And if you measure the LA volume, then hardly we can, slightly before that we can understand this LA volume is average, it is more than 34 millimeter of north. But if you do the strain analysis here, you can pick up in very early stage, and you understand what is the LA condition. So here Mr. Stephen Lister, the Mayo Clinic, and Fabian Nebel from the Berlin, they are the world authority, and the echo, and they have this here from
First
them.
of all, we look at this normal ejection fraction at a normal sized left atrium. But before we start with LA strain, we have to do the timing correctly. So we have to tell our software when is the opening and the closure of the aortic valve, and we have to tell the computer this is the aortic valve opening and this is the aortic valve closure. This is a continuous wave Doppler signal of the aortic valve. So then we go back to our 4-chamber view and start doing LA strain. To do this, we go on quantitative analysis, and you can see that the computer now knows the aortic valve opening and the aortic valve closure. The next step would be we go to the 4-chamber view. Now we have to know that this software was not made for the analysis of left atrial function. So we start here. We can see one pulmonary vein coming in and another one here on the lateral side. And now we start our analysis. And you can see that the tracking of the software is acceptable, at least in the basal segments, with a yellow color and with a red color. Now I'm going to exclude all the segments I don't want to have in my analysis. I have only the basal septum and the basal lateral wall, and now I get a very nice curve. The scale doesn't fit here, so I have to adjust the scale. And now you can see the LA curve. It starts here from the QRS complex, and you can see the maximum reservoir function, and you can see the values are around 45 and 47%. And now in this phase you have the conduit phase, and here starts the atrial contraction with this curve going steeply down. And you can see this is associated by the P wave of the ECG. So let's summarize the technical aspects to perform LA strain. First of all, we should only use apical views, and we should really narrow the angle of our views to increase frame rate and adjust depth so that you get a full image of the left atrium. The next thing is try to put your focus on the left atrium to get optimized images. Tell the patient to hold breath. It is quite important to have breath holding because otherwise you get translational movements of the left atrium. And then you should trace the contours of the left atrium. And in our practice, we only analyze the basal segments because in the other segments of the left atrium, you have the pulmonary veins coming in, the left atrial appendage, and the fossa ovalis.
That means you have seen only 2 segments as necessary. We have done in our experiment the full, all the conventional 3 segments, and the bullseye is not necessary here. Bullseye is not necessary here because only, and it takes a less time from the LV assessment. And LV assessment, it is not the this vascular pattern of the LAD, the circumflex, right coronary artery in that way in the LA. So this is unnecessary wasting time there. Only the 2 segments, the basal segments close to the annulus, this is only necessary. So this is the take-home message, because what we have done in our experiment and what the experts are doing. So So you have seen the methodology. Now watch a few interesting cases. You see, this is this healthy control where the LA is a good contracting, but here it becomes flash. This is the atrial fibrillation. There is no contracting power. Here it is this contracting power is also there, but it is absent contracting power. It's almost flat.
Right, a healthy control, and on the right-hand side, a patient with atrial fibrillation. And you can clearly see that on the left side, you have a preserved left atrial strain with peak values of around 40%. And you can see the atrial contraction. And in the patient with atrial fibrillation, you can see that the whole signal is blunted and you cannot see an atrial contraction. Okay, we have selected the 4-chamber view, and we have already performed the timing intervals of aortic valve opening and aortic valve closure previously. So let's start right away with the strain analysis. We start with the 4-chamber view here, and now we do the contour of the left atrium, and make sure that you get all segments in your analysis. Okay, so this is fine. I am happy with this. Let's process. And now I'm going to exclude all the segments that I don't want to see. So in the end, I have the basal septum and the basal lateral segment. And now I get my result. You can see that the lateral segment has a left atrial strain of around 10% and the basal segment of only 5%. So in summary, this is a highly reduced left atrial strain. And you can see here that the left atrial contraction is very low and practically not present in this patient. Also being reflected by the very low A wave that we found in transmitral analysis in this patient. It's because normal values for such a new parameter are maybe not available, but there are some meta-analysis, and they have calculated that a normal reservoir strain is around 40%. And I think we can remember this value. The peak left atrial strain is around 40% in healthy persons. And this is derived from more than 2,000 healthy persons, this meta-analysis. Okay, so the next question would be, in which diseases can we actually use left atrial strain? And first of all, we can use it to assess stroke risk. And this is a question that is brought up very frequently in echocardiography. The question, can we assess stroke risk by echocardiography? And we know that the dysfunction of the left atrium starts by fibrosis of the left atrium, leading to inflammation and a prothrombotic state, then LA dilatation, stasis of blood flow, then atrial fibrillation, and in the end, the patient might have a stroke leading from a thrombus of the left atrium. And usually we start anticoagulating patients who have atrial fibrillation, but the underlying subtle changes are usually not treated by anticoagulation. We know that LA dilatation, as we have discussed earlier, can be measured by LA volumetry, but the fibrosis of the left atrium can be measured by LA strain. So with this method, we can really measure something that is in the early stages of this long continuum of stroke risk. But the question was, do other methods also have the possibility to measure LA strain? And here is a study where a working group has performed MRI of the left atrium. And you can see two patients. On the left side, a patient with only very mild fibrosis. On the right-hand side, a patient with pronounced fibrosis of the left atrium. And on the right-hand side, you can see the echo curves of LA strain. And you can see the patient with mild fibrosis has preserved LA function, and the patient with a high degree of fibrosis has a blunted signal, reflecting that MRI and echo can both reflect and measure the degree, indirectly the degree of LA fibrosis. With atrial fibrillation, we all know that we measure the CHED-SWAS score every day. But this score is not optimal because it does not incorporate any parameters concerning the left atrium. And actually, no echo parameters are incorporated in the CHED-SWAS score. And let's look at the guidelines of the European Society of Cardiology concerning atrial fibrillation. They say there's a class 1 indication to perform transthoracic echo in AF patients to guide management, but it is not actually clear and look at the left atrial appendage for several reasons, obviously to exclude thrombi, but the flow in the left atrial appendage is also a marker that is very important because it tells us something about the stroke risk of these patients. And this was underlined in the study. You can see patients with a very low flow in the left atrial appendage have an increased risk for cardiovascular events. And here are a couple of examples of a patient with a very low flow in the left atrial appendage. And on the right-hand side, you can see a patient with a very high flow in the left atrial appendage. And the left patient has a much higher risk for stroke than the patient on the right-hand side. But not only the flow is important, also the morphology of the left atrial appendage is important. In this CT study, the authors have found out certain specific types of left atrial appendage forms: the cactus form, the chicken wing form, the windstalk form, and the cauliflower form. And why is this important? Because the stroke risk depends on the form of the left atrial appendage. And to make it easy, you can remember patients with a chicken wing morphology without any trabecularization, they have a very low risk for stroke, and those with non-chicken wing, they have a high risk for stroke. But coming back to our left atrial strain, in this very interesting study, the authors have divided patients with high and low CHET scores in groups with decreased and normal LA strain. And you can see that those patients who have a high CHET score and a reduced LA strain are the patients with the highest, significantly highest stroke risk. So LA strain can help us to determine the stroke risk in our patients. And one very recent study from this year has shown that the more reduction of LA strain you have, the higher the cryptogenic stroke risk is. And you can see values below 20% are associated with a much increased risk for cryptogenic stroke. So now let's move on to a different topic, diastolic dysfunction. And here you can see a healthy control patient with a normal left atrial strain. And here you can see a patient with heart failure with preserved ejection fraction, normal EF, atrial fibrillation, and the LA strain in this patient is very low, only 9%. And this is representative for the different stages of diastolic dysfunction. In this very recent study, the authors found that normal patients have a very good LA strain, but according to the degree of diastolic dysfunction, LA strain is diminished. So we can pick up gradual changes in correlation to the degree of diastolic dysfunction. But the question is, can we even pick up changes in patients who are only at risk for diastolic dysfunction? And in this large study here, a large cohort of patients were examined, healthy patients, and those who had underlying diastolic dysfunction already had decreased LA strain, and those with severe diastolic dysfunction have a high degree of reduction of LA strain. So we can even pick up subclinical changes by LA strain, and this makes this method for me quite interesting. To summarize the topic of LA strain, I believe that the dimension of the left atrium and assessment of the function of the left atrium are very important, that LA strain measurements are feasible, and that impairment of left atrial strain is associated with diastolic dysfunction, stroke risk, and worse outcome after electrophysiology for atrial fibrillation.
So last time the Dipak Gupta presented the cryptogenic stroke, how LA is important. That shows here. So LA strain assessment is how important that is there. So this is his Sir Harvey Feigenbaum, father of the echocardiography. You see, when I was young, long back, we have learned simple and the basic echo skills from him. I have kept this textbook with his autograph as a memento with me. With the passage of time, still it is not so complicated, and the strain, now the latest thing, actually means the change in the shape actually. So we have to stretch ourselves and continue to learn more and continue still the last heartbeat. So this is the stretching. Thank you.
Excellent deliberations, Dr. Sarkar. Now I would request Dr. Dipak Gupta to say a few words, followed by the question that may come from our audience. Dr. Dipak, your take on the whole talk and how Dr. Sarkar has nicely said. Your voice is not coming, Dipak. Yeah. Yeah, go ahead. No, still it is not audible.
So your mic is on mute, I believe.
Yeah, now it is okay. Fine. Oh, no. He's not mute. He's unmuted, I believe.
So remove the earphones and speak directly.
Yes. Can you remove? Plug it.
Hello.
Yeah.
Yes, sir, now you're audible.
I think is very good, very excellent demonstration by Dr. Arun Sarkar, and the importance of this tissue tracking and GSL, importance of GSL, GLS in all the field of the cardiology, and I think one thing we have left is the rheumatic heart disease, importance of rheumatic heart disease, GLS in rheumatic heart disease. But I think everything is demonstrated very nicely by the Arun Sarkar. I think a lot of questions from the speaker will be there, from the audience will be there. Satish, any question from the audience?
I have not seen any questions coming till now. Ashish, can
One
you?
question from my side, Dr. Arun Sarkar.
Yeah.
What is the role in the pediatrics patient and congenital heart disease? Any role of this tissue tracking in the congenital heart disease or in the pediatric cardiology?
Pediatric cardiology, there is increasing documentations are there, but because it is a new entity, so nothing has been standardized till now. But anecdotal reports are there, especially the structural things, the so many other conditions, metabolic diseases and depositions, the storage diseases, and anatomical things are already you can see there. But the functionality, of course, I've shown on a Duchenne muscle dystrophy. In that case, I have not shown the strain imaging, but as a muscle changes, there is also the cardiac myocyte changes are early, can be detected there.
Dr. Sarkar, a very nice presentation indeed. You have briefly touched upon the topic of post-systolic shortening. Don't you believe that we are using less often this very important, parameter for assessing the reversibility as well as, the ischemic reversibility of myocardium, particularly in coronary artery disease patients, to look at the hibernating myocardium. What's your take on that? I think we should use more often than compared to what we have been doing for assessing this reversibility issue, more than nuclear medicine and other parameters.
It is a cheap and a bedside technique, and our main purpose of to present these things to the general audience is that it is a new thing, and this knowledge should be propagated and properly to everyone. Really, you are correct that we are really using these things in the less amount, as so many things are new to us also. But we should use these things, we should apply these things in our clinical advantage.
And probably also because they have not been standardized through all machines of all vendors, I believe. Probably some of the vendors do differ in their reportings and values. So that may be the one reason, I believe.
Yeah, the standardization and the validation, there is a problem with the different vendors have a different values. But now there is a aggregation of in the world scenario. Now what I presented, the GLS and other things, they are well accepted and well standardized by the American College of the Cardiology and the European Cardiological Association. So these are there. Any uncontroversial things I have not presented.
Okay, very nice. And very rightly, sir, you have explained about the importance of atrial strain. Actually, this was no new for me also. Let me accept this. And how they should also be considered other than CHATS score in starting anticoagulation in those patients who have been found to have atrial fibrillation. Now they have reverted to sinus rhythm, but whether we should start it or not, this is one consideration which one should also look into other than CHATS score, as you said. Sir, I would also like to ask Ashish or anybody else from GE, they also should come out with what is new in now this in the role of AI in the functionality of newer echo machines, if they have anything to say on that, and about the data validation vis-a-vis different vendors with the strain echocardiography. Ashish, you may, or anybody else can speak on that if you have anything to say.
Thank you, sir. Thank you for the opportunity. I really want to thank and compliment Dr. Arun Sarkar, sir, for this wonderful session. While the presentation has been shown to the screen, I would like to thank, and I feel proud in one statement, that in 2004, when G has started this journey of speckle tracking, it was like a research tool, and in last 16 years it's a roller coaster ride. And as you can see today, there are so many diseases or the prognosis factors where we can use strain in our day-to-day practice and make the patient a better patient care to our healthier India domain. And with that, as you rightly projected, sir, there are a lot of new excitements which is coming in speckle tracking. And while we talk about the speckle tracking, the most important feature that I would like to touch base is the time, because in India we have a lot of volumes. And while we are talking about the speckle tracking, the AFI is the name given to from GE, which is called as automated functional imaging. And while we are talking AFI, we, as Dr. Sarkar has clearly stated, that 3 apical views are required: 4-chamber, 2-chamber, 3-chamber. So I have to manually go and select the views, and I have to do the pointing so that the tracking can be done. But now, with the help of the AI, I don't need to select the view. System will automatically recognize that this is a 4-chamber view, and system will do the tracking and gives the results in less than 10 seconds. And at the same time, it gives us the ejection fraction automatically in the same package. So the time that we take today for doing an ejection fraction, in the same time, if I'm going to get the strain, that's what we have been dreaming for, that it takes lesser time and able to provide us the entire information. So the workflow that is required today, which will help you to reduce the time for doing a strain, has gone very low. Like earlier we used to say it used to take 3 minutes for an accurate analysis. But today, is this required? No, because of the AI, thankful to AI, that it takes less than 30 seconds for completing the entire strain. So while we talk about the accuracy, the endocardial strain is always going to be higher. But when we are talking about subclinical LV dysfunction, the myocardial strain has the equal importance. So while GE is the leader in echocardiography strain, we track all the 3 layers, and if there is a sigmoid or a scarred segment, we can change the width also. At the same time, while we are talking about the workflow enhancements, the biggest challenge that remains to an echocardiography room is the image quality. And while we are talking about the image quality, it is our duty to elevate our image quality so that you can do strain in most of your patients, because if the imaging is not good, speckle tracking doesn't work. So we have a dedicated, exclusive, patented beamformer technology, which is called as C-sound imaging, which improves the imaging even in a non-diagnostic exams or a subclinical imaging. So imaging has been enhanced, the workflow has been enhanced, and with that, while Dr. Arun Sarkar sir is taking so much of time and showing that how strain is important, we have a proud saying that when the ESC, the European Society of Echocardiography, standardized the strain and they try to see the strain values in our transmural segments, the normal and the abnormal segment, and the distinction between them. The GE is a clear-cut indicator in the leadership while it comes to the speckle tracking echocardiography. The GE strain has been highly accepted with more than 400 papers which has been published on GE strain. And we really have a proud saying that the GE strain has really helped in making a clinical diagnosis better. While we are talking about the strain, as Dr. Dipak has very clearly asked that which of the modalities it is really helpful. Like when it comes to leukemia, it doesn't see the age. So probably in pediatrics also, we are seeing a lot of patients or incremental value of doing the strain. And this is one of the papers which has been published on the GE imaging. While in the patients, while we are talking about the surgeries required in the pediatric patients, the impaired strain is the first indicator of the RV dysfunction. And I can proudly say today, this is the future development which we are working on. It will be automated, and at the same time, the time that we take for doing TAPSE, with that, it will give us the global strain and the free wall strain. So all the 3 informations will be completed in less than the time that we used to spend for the TAPSE. While diastolic dysfunction is important, can we make it easy? Can we make it more improvised workflow? So today, the volumes that we measure, volume is the last prognostic marker or a biomarker where we say that the function has been reduced. The first thing that affects is the strain. So again, the early diagnosis can be done with the LA volume plus strain in a lesser time. With the emptying fraction, reservoir, conduit, contraction, everything is automatically calculated. So the fundamentals of today's this technology development is that while we talk about the imaging, it makes it easier. So now this is going to be an eye-boggling for everyone today, sir. While LV study is the most important study for every echo that we do. So here, I just need to press a auto button. System will automatically find out the diastolic, systolic frame, and the ejection fraction is being calculated. This is based on the ASC guidelines on 2018, and the time that we take for doing a consistent study on the parasternal long axis view, while it may take a longer time, here it's just a click of a button, diastolic, systolic frame will be calculated, and your ejection fraction, LV mass, stroke volume, everything will be calculated by the system. At the same time, the next will be even more mind-boggling. While we talk about saying that cardiac auto Doppler trace that we have to do, so we have to tell the system that mitral valve, and then we trace it, and we may probably trace it for one particular cycle. So like in this example, you're seeing a sample on the aortic valve, and there is a LVOT trace that I need to do. So now what I need to tell to the system, a pressed measure button will do everything automatically. System understands this is a 5-chamber view. System understands that our sample is at aortic valve, and system automatically completes the measurement with just a click of a button that is called as measurement. So AI is a long way, and it has been creating another environment for doing an echo. So this is from our side, sir, from the GE to the echo lab to structural heart interventions to strain, early diagnosis, improved workflow, and a consistency that you can provide to your patients in even in ectopic beats where you can take multiple traces in your regular day workplace. The time that you have to do on these repetitive tasks is enormous. While you will be using this technology, I am sure, sir, as a technology provider, it's our duty to make your workflow easier, simpler, and you can give a better patient care. And that's the theme that we are working in Vivid Technology, sir. Thank you so much for giving us this opportunity. Over to you, sir, for question and answer, sir.
The tissue tracking is available with the team transesophageal echo?
Yes, sir, it's available, sir.
It can be done in the intraoperative also.
Absolutely, sir. Bullseye.
So, if there are no questions, we are just completing time also. So, we can wind up.
So I have a question for you, sir. Sir,
Okay.
while we are talking about the GLS, would it be preferred to go for endocardial strain, or all three layers should be considered?
Yeah, I think Dr. Arun Sarkar should answer this very clearly. I mean, presently, yeah.
Worldwide, there is a difference of the opinion. Somebody has concentrated on the this endocardial towards the mid-zonal, sometimes the epicardial towards. So this GLS value actually differs from the vendors to vendor. It is because there is no agreement of the which is the exact site. But now there is agreement. The endocardial strain should be very closer to the endocardium, because that is the very earliest part. The longitudinal fibers are there, and that gives the maximum importance and clinical correlation.
Is there any new information, Ashish, on that?
So, sir, while we are talking about GLS in GE, sir, there is a European Society of Consensus which has happened, which says that all three layers should be considered, and as there is always a conflict of interest, what G has done, sir, we are giving both the options now in our system. So like if you wanted to see the same patient with only endocardial strain or all the three layers, that will be just a click of a button, sir.
Okay.
But one thing
That's
is
why there are three lines coming for each layer.
Just one thing I have to add. When we observing the bullseye, the 17 segments, the one segment of the bullseye doesn't differentiate between the endocardium to epicardium. The strain value is the average of all three segments. Okay, so just like doing the ECG as an endocardial damage or a damage, just like a angiography that gives that value, the MRI value. So you can extrapolate these things from the bullseye. That is the limitation that we have to understand.
Well said, sir. I completely agree with you, sir. So the clinical indications needs practice, and since this topic for the beginners, but the way you have elaborated each and every points, I'm very sure, sir. Even we are talking about diastolic dysfunction, 10 out of 7 times. I mean, 7 out of 10 times, it is completely mind-boggling, and we are in confusion whether it is a grade 1, grade 2 pseudo-normalization, but with a very clear indicator, and if you can use it in the same time that you have to spend for the volume measurements, it will be very helpful for using it into a different domains of exercise, sir.
Yes. What I believe is that this is one tool which help us in detecting patients who are preclinical in all aspects, whether it is coronary artery disease, whether it is diastolic dysfunction. So you can pick up patients even before they have started having symptoms. Like in hypertensive heart disease, if you do progressive, of course, it may be more of theoretical, but there are situations where you get confused that if somebody is having dyspnea on effort of unexplained reason, And many times looking at strain echocardiography give you a lot of information and explains things. So with that, I believe we should close this session now. And I'm really pleased to, thank all of you, particularly Dr. Arun Sarkar sir. It was so elaborative. It was so, the experiments that he did with the rope and that was splendid, sir, to explain things. This is how real good teachers teach students. And thank you, Dipak, for being with us.